Alright, I'm gonna have my patient flex. I'm gonna apply a downward force. I'm gonna externally rotate at abduct. Do you have any pain here? Look for apprehension of pain. This will be indicative of joint pathology. It's not specific. I'm performing on the other side. Downward force, I'm gonna externally rotate.
The hip scarring / quadrant test. So make sure that when you perform this test, make sure now, what am I going to do? What am I about to do if I can? I'm gonna lower him a little bit more. Okay. This is where I can keep my foot, I can use my body weight. So I can drop my body weight down to keep the downward force applied. Then I'm gonna adduct him, right? So adduct him, and then I'm gonna externally rotate. So I'm gonna repeat that about 3 times with external rotation, all right? I'm gonna keep him in adduction, then I'm going to internally rotate. All right? Nice and smooth. So I did kept them in adduction. I externally rotated 3 times, and then I internally rotated while also paying attention to my patient to see if there are any grimacing, any pain. If your patient in fact has a hip joint pathology, that is the hip scarring test is most likely going to reproduce pain. And so who did we say which approach looked at on that table that we read? Which of those approaches looked at reproducing pain with special tests and measures? It was Syriax, Manel, and the osteopathic approach. Which one placed the emphasis on that? Relax for me, relax. All right. Do you still feel my downward force?
Yes, sir.
Okay. Okay. So that's the hip scar quadrant test. All right. So a positive finding would be pain or apprehension indicative of hip joint pathology such as arthritis, osteochondral defects, avascular necrosis, or acetabular latent defects. Yes, sir.
So I know a positive test is pain reproduction, but also if there's like joint grinding or dysfunction and it doesn't present as painful, would we verbalize that?
You can. So you can always verbalize what you feel. So we're not looking for you to verbalize the end feel on a special test unless it entails it. One test that may entail it, that you could probably delve into it, but it may not be required, is a test for the hand. Which test is that? The Bunear Licker test. So you may can delve into it then with the Bunear Licker test. Because remember, with Bunear Licker test, you're looking at the soft tissue restriction or it being a joint capsule restriction. So if it's a joint capsule restriction, then you may delve into discussing the end field if it's a joint capsule restriction with the Bunear Licker test. All right. That's the Craig test on page 241.
So Craig's test, I'm going to externally and internally rotate, palpating the greater trope until it's parallel with the mat or floor. Can you hold this position here? be, a stationary arm is in line with the tibia.
Anterior aspect of the
Anterior
tibia.
aspect of the tibia.
And where's your movable arm aligned to get your measure?
Long axis of the leg, so
Your movable line, your movable arm is gonna be in line with the femur.
okay. 0 to 15 degrees. And I believe according to the test, if it's 8 or less, it's retroversion. If it's greater than 15, it's anteversion.
Yes, sir. So, correction, according to the book, it says that while the examiner measures the angle between the long axis of the lower leg and the perpendicular axis to the table with the goniometer. So the movable arm is gonna be perpendicular to the table. So what does that mean? So take them back, take the measurement, right there. All right. I feel the greater trochanter being in line with the table.
So you say the full arm.
It's gonna be perpendicular to the treatment table.
Okay.
You're saying the stationary arm is perpendicular to the table, and then the movable arm is in line with the anterior aspect of the tibia. Yeah, long axis of the lower leg.
So I got 0 to 9.
Okay, there we go. So 0 to 9 degrees. So what would 0 to 9 degrees be indicative of?
Neither, because it's not less than 8, it's not greater than 15.
So that would be normal.
Yes, sir.
All right, good job.
Are they
So what the greater trochanter does, so if the femur is if the femur is in external rotation, then or excessive internal or external rotation, if it is in either of those positions, then the greater trochanter will not be parallel with the treatment table. We have to rotate the femur so that the greater trochanter becomes parallel with the treatment table. So we're trying to make the greater trochanter parallel with the So 0 to 10 degrees, 11 degrees. So what is that indicative of? That's normal. I got my hip right here, right? So got my greater trochanter. See my fingers over the greater trochanter? If I so see how this is external rotated? So now, with this person being in excessive external rotation, the greater trochanters are not parallel with the mat. Can you see that? So now I want to palpate the greater trochanters so that they become parallel with the mat, like so. So now they are parallel with the treatment table. Now if I go into more internal rotation, then they're not parallel with the treatment table. Does everyone see that? So now you got to be able to palpate them to feel where they are. So, and when you feel them, you palpate it. So I'm here palpated, and so as I palpate it, this is what I'm feeling for to be parallel with the table. Does that make sense now? Okay. So once I get this parallel, once I get the greater trochanter parallel with the table, now I can then ask the person to hold the position of his lower leg, and then now I can take the measurements. Okay, that's how you identify and make sure that the greater trochanter is parallel to the table. This is the positioning that you want. So you don't want it like this. You don't want the greater trochanter like that, because down is not parallel to the table. So you don't want excessive external rotation, and you don't want excessive internal rotation, because now the greater trochanter is not parallel with the table. Okay.
May I
So
add
you
something
find that,
now?
go ahead, Dr. McClure.
So if you'll do the same thing you just did with it, so as you're palpating, I've almost heard it described as the most prominent. So if you can see when he can come back to neutral, when he goes down into internal rotation, it goes down and away from my hand, and then as he comes back to that neutral parallel position, or as he comes back to the parallel position, that trochanter it'll come into my hand, and then as he continues to go the other, it'll go away. So if you can find that position where it's coming into your hand, like the most prominent position, it's not going away from your hand, but right there where it's most prominent, that's the slider. That's where it's parallel to the table. So that's what it feels like, okay, as you're feeling that.
Thank you for that, Dr. McClure. Everybody good with that? Okay, all right. So when you practice it with your lab partners independently, that is what that looks like. We got the 90-90 straight leg raise test and the Faber/Patrick's test. So we need 2 more volunteers for those 2 tests. 44.
Kick this leg out. Alright, put it down, keep this leg out. Alright, down your hands and then your butt. We also got the space in 20 degrees. So what I'm looking for is when she's in the 99 position and she kicks this leg out. I'm trying to make sure that she's in the most extension she can be. So if she had at least more than 20 degrees of deflection, then she would have hamstring tightness.
Okay. So how do you know, how can you get an objective number with this? Okay. So let's see what it looks like with somebody who's wearing shorts. So thank you, Jada. We're gonna get Zatisha to come up. And we're gonna get a goni. That's good support. What's your alignment on your goni?
I have it on the extra now. Then I have this in line with the gray trochanter. Then I have this in line with the flower mantle.
Okay.
Keep straight it out. But she's still under 20, so she.
Okay. That's good. So you got, she had 0 to what, around about 18, something like that? And so that was normal. So anything less than 20 degrees of knee flexion is normal extensibility of the hamstring muscle. Let's see the other side. Because remember, you gotta assess both sides during the practice. So don't forget that. Now, what happens if you don't assess both sides during the practice? You're gonna get some, it's not gonna be worth it. So make sure you assess both sides, because you gotta look at both sides of the clinic.
For this one, like during the actual practical, you want us to measure?
Yes, good question. Yes, I do. Okay.
So I would say this hamstring is a little bit higher than this one, but they're both normal.
Okay. All right. Good job. So thank you. So that was the 90-90 straight leg raise test. If your patient comes with back pain, hip pain, knee pain, ankle pain, you may want to look at the hamstring muscle group. They can impact the lower extremity connected chain. If your patient comes with plantar fasciitis, you most definitely want to look at the hamstring muscle group. So I've seen patients come with plantar fasciitis and the culprit is tight hamstring. And so I've actually had patients on my caseload who I haven't even touched the plantar fascia and just worked on hamstring and hip. And guess what happened? Plantar fasciitis went away. Didn't do no ice massage to the plantar fasciitis, didn't do anything to the plantar fascia. It was worked on the tight hamstring muscles, weak glute muscles, then boom. Hey, I'm not having any pain anymore. Dr. Carter, when I get up, the pain is gone. I don't know what happened. Everywhere else I was doing ice massages, and stretching the plantar fascia, and it just didn't go anywhere. Where the problem was in other places. Yes, Liz.
Yesterday I was doing some, NMT / STT on my calf, but like in the, like foot ankle area, and like some of the ones I did on, it seems like having pain in hamstrings, so I wonder if they could be tight when I did some of that on them, since you were explaining that.
It could have been tight. He could have been trying to recruit the hamstring muscle group. He could have been compensating. So if he was compensating and trying to use other muscles, it could be that he could have, it could be some involvement of the hamstring muscles, but it could be also involvement of other muscles with the hamstring muscles trying to activate and substitute for something else that's lacking. You just have to put the pieces of the puzzle together. Sometimes patients will call me and tell me problems that they're having, and I'm like, I really can't give you a definite answer, because sometimes patients want answers. But I really can't give you an answer unless I do an examination on you. That's what I tell people. And you're gonna be physical therapists, right? And people are gonna be calling you, what's wrong with me? This is going on, this is going on. And I really hold off on telling people what you think it could be unless you do an examination. So I hold your clinical impression until you do an examination. That's what I would say, because people are gonna be calling you. And I tell them all the time, I can't really tell you, you have to come in for an examination. I'm sorry, but I don't want to give you anything misleading information.
Abram, the instance reflection, the AP is ambulation, ER is external rotation. So I'm gonna ask the patient to do is bring this ankle, this
There you go. So your classmates are not gonna steer you wrong. So a positive finding is revealed when the involved lower extremity does not abduct below the level of the non-involved lower extremity. This may be indicative of iliopsoas, sacroiliac, or even hip joint abnormalities. All right, let's assess the other side. Okay, so now this test is similar to the drop arm test in that it is non-specific. So you got several things it can be. So now, what if you think it's iliopsoas involvement? What are you gonna do? It's gonna transition you to the Thomas test. All right. So if you think it's sacroiliac involvement, then it's gonna transition you to SI joint test. Okay, you'll learn those in the spine. All right. And then if you think it's other type of involvement, it could be sartorius involvement. Okay. Then you go to assessing palpation exam, muscle selective tension testing of sartorius muscle. But it's giving you information if it is a positive test, and which could lead you to another special test to perform to rule in or rule out of what you think it could possibly be. So in her case, she reported what? You say some tightness? Mm-hmm. You feel like some tightness? So now she told me it felt like some tightness. So now I'm gonna probably look at her iliopsoas muscle. So let's go to page 259. Since she's up here, let's go ahead and do the Thomas test with her. I'm gonna tell you something else it could be with that one. It can also be the piriformis could be involved as well. So you want to scoot to the edge a little bit more. There we go.
patient legs both
Yeah, Y'all come look at this. Yeah. Already told them. That's positive right there. All right. Let's see what the other side looks like.
That one feels better.
She was able to flex her knees, right? So we saw flexion in her knees. She had a good amount of flexion in her knees. So I'm not taking a going, I'm just eyeballing this. So with her having good flexion in the knees, but decreased hip extension, what does that indicate? Ruled out rectifemoris, good job, baby, and indicative of iliopsoas tightness. So her Thomas test, because it could be positive for both, or one or the other. You see, some people can get down and get good hip extension, but not good knee flexion, not enough knee flexion, which indicates it could be rectus femoris tightness. So, like, I already had a clinical impression. Now, I had a clinical impression. It's not saying that my clinical impression was 100% correct. But after I circled back and I said, what did you report with that? With the Patrick Faber test? Tightness. She reported tightness. So I said, his likability, her Thomas test is gonna be positive. Because what does it indicate if the Patrick Faber is positive? Iliopsoas, sacroiliac, or any type of other hip joint pathology. Now, when we assess her piriformis muscle, anybody know how? So go to piriformis test 257.
So that brings up another good point too, right? So she says she felt tight, and when you do ask about infield, we may not be recording infield, but Kiki's probably making note when she goes down. Does this feel like muscular tightness, or does this feel like it's joint capsule stiffness, bone on bone? What do you feel? Because you're trying to figure out what could limit it. There's a lot of options, right? So then you're further incriminated by just working down. It felt kind of muscular tightness. I better check Thomas test and piriformis test. If it felt bony, or capsular, you might go to your situation.
My patient sideline on the non-testing side, not testing at the moment, with 60 degrees of hip flexion and relaxed knee flexion. I'm gonna have my proximal hand on the pelvis and my distal hand on the lateral knee. And I'm going to apply an adduction force on her knee.
And what are you looking for when you apply that adduction force?
If she has pain in her hip and foot, it'll be pure support, like, but if it was a butt or posterior thigh, it would be sciatic nerve.
Okay. So, Kiki said that her piriformis tests were negative. All right. So that is how you would assess the piriformis. So tightness or pain in the hip and buttock area is indicative of piriformis tightness. So lie back down. I saw some things. Pain in the buttock and posterior thigh is indicative of sciatic nerve impingement secondary to piriformis tightness. So go back to your side for me, please. Right there. There we go. Okay, good. I didn't feel a whole lot of resistance with that. I was able to do that easily. So I'm feeling for the amount of resistance that I may feel with this. Okay. So she got to the edge of the plinth easily when I did that. So I applied a little bit more force than Kiki. Okay, so I want to see if she can actually make it to the edge of the plant when you do that assessment. So you want to see if the person can actually make it to the edge of the plant when you move them in that adduction, hip adduction direction. The extensibility of her quadricep muscle, specifically her rectus femoris. So I want to see the extensibility of her rectus femoris because her hamstrings are considerably hypomobile. So this is why I want to look at her rectus femoris on the side. I'm looking to see and feel. So y'all see that? This is good. So she has good, her pelvis did not rise, so she did not go into hip flexion. So her hips stayed neutral. So this is fascinating. I'm gonna tell you all why. She has good extensibility of the quadricep rectus femoris on the left side. So let's see this. Come over here like so. Same thing over here. Very good. So very good rectus femoris extensibility. Okay. All right. Now, Liz, sit up for me. Sit on the edge of the pen. I'm assessing Liz. What do y'all know it a lot? Liz, I want to see if you could do a long arc quad. Okay. And do the same thing on that side. All right. Now, lie back down for me on your stomach. So she's able to do it. Go ahead and turn on your back for me. So let's see something. Who has he going? So doing 99 straight leg raise test. Dr. McClure pointed out to some of you all, you want to make sure you got a 99-degree angle. Go ahead, straighten this leg for me as much as you can. Lateral. Right, you go with. So, right now, she has 45 degrees of knee flexion. What is that indicative of? Yeah, so she has significant hamstring tightness on this side. So, fascinating. I'm trying to. All right. Go ahead and straighten this leg for me. So on this side, she has 31 degrees of knee flexion. So she still has tightness on this side, but when I compare the two, this one she is greater restricted. So she has less extensibility on the right side. So she has to work on that. That can cause problems. So she has less extensibility of the hamstring muscles on the right side. She has a little bit more extensibility of the hamstring muscles on the left side. So go back and listen to the terminology that I'm using and what I'm saying. Also, I could also say that she's considerably hypomobile with hamstring extensibility on this side. Okay, or hypomobile with flexibility per se of hamstring muscles on that side. All right. So now, based on Liz's presentation, so she was able to do a full long arc quad, right, in a sitting position. Why did I want to see that? Yeah, so I at least want to see her quad strength. I'm trying to assess for muscle imbalance, but I want to at least see her quad strength actively. I haven't done any manual muscle testing yet, but I can do that. And then I want to see what she did actively with flexion. So now, let's see. Go ahead and turn on your stomach for me. I almost assess the entire hamstring muscle group. So go ahead and bend your knee for me. Good, relax again. All right, bend your knee for me again. All right, I want you to hold this position and do not let me move you. And hold. So, hold this position, do not let me move you. So, she's weak, she's unable to hold her position. So, typically, tight muscles are typically wet. Weak. They're typically weak because the person typically doesn't move that muscle throughout its full range of motion, or works on strengthening that muscle throughout its full range of motion. All right, go ahead and sit up on the edge of the plank. So now we gotta work on extensibility, improving her hamstring extensibility. Somebody's in here gonna have to help Liz. Come to the edge. So we gotta work on improving her hamstring extensibility along with strengthening her hamstrings as well. So we gotta do some soft tissue work and follow that with some concentric and eccentric strengthening exercises. So see how one thing can take you down to somewhere else and start looking at other things. So now, based off her hamstring 90-90 straight leg raise test, I have a strong kind of impression that she has a muscle imbalances between her quadricep and hamstring muscles. So her quads are significantly stronger than her hamstring muscles. And her hamstring muscles are considerably hypomobile or extensibility. All right? So that's how you should be using information. So when I saw Liz, I said, oh man, she's a perfect candidate to show you how you use information from a special test, or you could use it from passive range of motion, or you could use it from active range of motion. It doesn't matter. One test and measure should lead you to another one to get more information. That's how our physical therapy examination works. And then what you do, you identify problems, all right? You identify the problems, because likely it's the problems, the impairments that are resulting in the functional limitation.
So you're gonna have the patient stand here and flex their knee. They're gonna hold that position for 10 seconds. And there is some movement on the uninvolved side, which is indicative of possible glute knee weakness. And you wanna make sure you look at the anterior aspect and the posterior aspect. As you can see, significant drooping on the uninvolved side. Glute knee gotta strengthen up.
So he's positive? Okay. All right. That's because we never work in the frontal plane. We don't do frontal plane work. Most sports injuries occur with plane. Do we know? Frontal plane, moving lateral.
Fix their left leg, the left knee. And then hold that position for 10 seconds. Want to make sure you're looking at the anterior view and the posterior view on the uninvolved side. So that means that this is a negative test. So that means he has a strong left glute knee muscle.
Okay. All right. Good job. Now,
Abduct and flex the patient's knee to 90 degrees while stabilizing the trunk here. Now I'm going to slowly lower the patient's leg toward the table, and it is stuck here.
it's stuck right there.
So IT band tightness. Now we're going to assess the other side here. So you abduct and flex the knee to 90 degrees while stabilizing the trunk. Now I'm going to slowly lower. So he was able to adduct properly, which is a negative test, which means he has a strong left IT band.
So now, if you verbalize that on the practical, what type of grade would you give that verbalization?
This was
So you say he has a strong, it indicates that he has a strong IT band.
flex.
There you go, extensible, flexible IT band, okay? So he has normal, extensibility of the left IT band, or
And we would
normal
get the-
flexibility.
Then we would also give the
That's for excessive motion, so that's good. So if the test is assessing the extensibility, that's what your verbalization wants to be. You wanna inform Dr. McClernand about the, if it pertains to extensibility, that's the terminology you wanna speak and use. All right, extensibility, flexibility, okay, yes.
So are we telling them to lower their leg, or are they dead weight and we just guide them?
Let's see what Coleman says.
It just says, allow the leg to lower slowly.
So looking at Coleman, it's looking like you can guide it down or just be there. So really she removes the hand and just allows the person to lower the leg, slowly. Okay. So thank you. And that would have been done as well. All right, so now for more nerve traction tests. This is one more, then we'll practice these up until lunch. So for more nerve traction, who's a volunteer for that one? All right, thank you, Tia.
Decide for me. Or either way. So if you'll bring this knee up to your chest a little bit. Bring this knee up to your chest a little. No. Slide up. Yeah. Good. Okay, so one hand on the lateral aspect of her involved pelvis. Supports her leg below the knee. Okay, that's the head. If you'll bring your head down to bring your chin down to your chest a little bit. Okay. And then really extend subject's knee and the hip. Approximately 15 degrees. I'll say about right there.
So in this case, you're gonna end up flexing the knee.
Flex knee.
There we go.
Okay.
That's it.
So flex. So extend and flex. Question mark.
So first flex the knee
Okay.
and then extend the hip.
Okay. Right there. Okay, do you have any pain?
No, it was uncomfortable.
Alrighty. So if you have pain on the anterior side of her thigh, that will indicate decreased mobilization of the femoral nerve.
Now, based on what we've learned about descriptors of pain, what type of pain do you think she would report?
Radiating.
Yeah, radiating, shooting pain, sharp pain, maybe numbing, tingling, some type of abnormal sensation of paresthesia. Okay, all right, the other side.
Okay, and then bring your chin down your chest a teeny bit. Good.
There you go.
Do you have any pain with that? Alrighty.
What do you feel?
Just like a long stretch.
Okay. All right.
Okay, sounds good to me.
So notice, to get more out of your patient, notice how I ask an open-ended question, like what do you feel? Because now whatever she says that she feels is gonna take me somewhere.
Right.
Okay? And so she said, I feel a stretch, I just tightness with this, then now I'm gonna go, okay, Thomas test.
Okay. But if it's a stretch, wouldn't that be normal? Because you're stretching her leg?
Well, I'm just gonna assess it to rule it out.
Okay.
being tight because she told me she felt a stretch.
Okay.
And so it just depends on, I may come back and say, well, did it feel tight? But based on what she says and the timing that I have in the clinic to work with her, I'm gonna try to get a little bit more information just to see. You know, but good job.
Thank you.
Looking at the humeral head of the humerus in reference to the glenoid cavity, what condition do we have going on?
Superior subluxation.
Superior subluxation. So how do we know it's superior subluxation?
Because of where it's placed on the glenoid cavity.
Yeah, so it's not all the way out of the glenoid cavity, so we can still see a portion that's intact with the glenoid cavity. So now we know we have a superior subluxation, because subluxation means that part of the humeral head is in contact with the glenoid cavity. But what if the humeral head was totally outside of the glenoid cavity?
Dislocation.
That's dislocation, okay? And now, if this patient is referred to my clinic and they already sent me the x-rays, and the physician or orthopedic surgeon says, Dr. Carter, I'm gonna hold off on doing surgery. I wanna see how this patient benefits from physical therapy, and we're gonna take x-rays again after physical therapy. What am I thinking before this patient even arrives to my clinic when I see this? Based off what I know about anatomy.
You're gonna strengthen the muscles that pull the humerus down.
So Tavian says, I'm gonna strengthen the muscles that pull the humeral head downward, that provides an inferior force on the humeral head. What muscles are those? Those are the rotator cuff muscles, because the rotator cuff muscles provide an inferior pull to the humeral head. So now when I see this, I already know, oh man, this person needs rotator cuff muscle strengthening. Now, this person may also need strengthening of the scapular dynamic stabilizers as well, because the scapula is looking like, to me, so I'm looking at the scapula, it doesn't look excessively lean, but I'm gonna work on those muscles as well too. So I'm gonna work on the scapular dynamic stabilizers as well. I'm gonna assess them to see where they are. You know, I'm gonna assess her upper trapezius. I'm gonna assess her rhomboid. I'm gonna assess her serratus anterior, serratus posterior muscles. Okay, because we know how to do that, right? So we can assess those in the rotator cuff muscles. But this right here, this is not good. Now, this person is sublux. This is referred to as instability as well. This is a form of instability. So subluxation and dislocation are forms of instability. You got that? So now, if those are forms of instability, when this person comes to me, and I'm gonna be so concerned with assessing accessory motion, that's not gonna be a major concern for me, because I'm looking at the x-rays. Is my line of treatment gonna include accessory motions? Most likely not. So what am I gonna work on? Strengthening and stability. That's gonna be the go-to. Okay, strengthening and stability. Seeing this. So now I strengthen and perform stability for 8 weeks. The person goes back to the orthopedic surgeon. Orthopedic surgeon says, Dr. Carter, I'm gonna see this person back in 8 weeks. I'm gonna do x-rays. What is the doctor looking for when he does the x-rays in 8 weeks? See, if it starts to come back down. You see, this is what we have to know as PTs. This is how we have to operate and function. You see, this is the task that we have. So yes, sir.
Being that you already have the x-ray and you know it's subluxation, would you still do a posterior or anterior apprehension test just for your own findings? Or?
I could, yeah. So I could. So with me having imaging is not all inclusive. I can still do posterior apprehension, anterior apprehension test just to see what happens. You know, I still can do a SOCA sign test, just to get information. So yes, sir. I still can assess passive range of motion. I still can look at active range of motion. You know, I still can do manual muscle testing. I still can do testing measures within what I'm capable of doing into the patient's tolerance. So the patient may not be able to tolerate a whole lot, you know, beyond a certain point. So when I assess passive range of motion, the patient may be like, man, this is as far as I can go, Dr. Carter, and I'm gonna halt right there and say, okay, if this is as far as you can go, this is our baseline. I'm gonna record that as the baseline. So as far as she's gonna tolerate is me taking her to 60 degrees of flexion, I'm gonna stop right there at 60 degrees of flexion with passive range of motion and notating, you know, and there's gonna be a baseline assessment. If we can come back 8 weeks later and I'm able to get her to 130, 140, 50 or beyond with passive range of motion without it being painful, then that's improvement. You know, because I'm notating my baseline and I'm notating what I progress. So this is what we do. This is good. This is a good teachable moment. So I forgot to discuss my infields that I assess with her. So my infield assessment bilateral, I'm gonna say normal, firm, ligamentous infield. Normal, firm. And so since it was stretched, that's why I'm saying firm. Ligamentous, firm. Because with traction, we don't get a separation, a true separation of the joint space. And also with this right here, there's gonna be some type of inferior gliding occurring. So just note that. You know, take a mental note of that. All right, who's coming up? Who's the patient? Okay, thank you, David. Okay, so now, all right. So I gotta be in the gym, I gotta be working out, I got somebody strong here. So as a PT, you gotta be strong, right? You gotta know what you can do. So now, all right, I don't have a tech on hand. I'm in the clinic by myself. What am I gonna do? Picture 1, picture 2. So obviously I have no choice but to do picture 2. So I'm gonna come here, I'm gonna take this hand and stabilize the pelvis. So my hand is coming around his anterior superior iliac spine. All right. The palm of my hand. I'm gonna grab the posterior aspect of his distal thigh. All right. So I'm gonna use my fork. I'm gonna use my arm and put him against my chest. And I kind of want to bias him into some external rotation. Why do I want to do that? Yeah. So now I have my hand blocking the pelvis from moving. And now I'm using my body with a weight shift. So I'm not using my arm to pull, I'm weight shifting my body. Okay? And so this right here, I'm assessing. Okay? What I feel. So now I do know this, but I'm gonna see what this side feels like first. Again, my arms are long, so that helps me out. And I'm using my body, blocking his pelvis from excessive movement with my hand, and my force is going, my shift is this way. Okay, my shift and my weight is this way. So with that distraction, some gliding is occurring, inferior gliding. So now, let's go to Norkin and White. Let's make some correlations here. Go to hip flexion. This is gonna help you with preparing for the practical. Somebody go to Dutton, I think it was in the infield with hip flexion. What does it say? How about abduction? Firm where? What does it say? The inferior medial joint capsule. All right, with abduction. So the clinical pearl. So the clinical pearl, let's see if it aligns. Let's see if this correlates. So we're moving convex on concave, right? So whereas if convex on concave glide of the joint surfaces is restricted, there is an inability of the moving surface to glide into the contracted portion of the capsule. Does that align? Yes. So now, what should I feel? I'm moving convex on concave. I'm doing a distraction, but typically what occurs is some inferior gliding as well because it's not a true distraction. So what should I sense as the portion that is producing my normal firm infield? Inferior. So the inferior joint capsule and the inferior aspect of the ligamentous structures should be tightening. So in that case, it aligns with what is in Dutton and also what is in Norkin and White. Okay, is everybody so good? So now that I assess both sides I would grade if I'm with accessory motion, both sides if I'm grading using a Paris scale. So I'm using a Paris scale, 0 to 6 Paris scale. So if I'm comparing bilaterally, I'm gonna say it was normal. So no side was hyper or hypo in comparison to the other. So he would get a grade 3. But say if I felt one side more hypermobile than the other one, I would verbalize it that way, okay? Then I'm gonna come back and verbalize the infield. So his infields were normal. So don't forget your normal versus abnormal. So in his case, I'm gonna say a normal, firm, inferior capsule, inferior ligamentous structure, infield. Does everybody get that? So this is how you wanna verbalize it on your practical exam. And this is what you wanna be getting a feel for with your patient, all right? So, thank you, baby. So now, oh, you come back, Tavian, my bad. Let's show it another way. So now, if you have the lesion of a tech, that tech is not bogged down. So if your tech is not bogged down with timers, okay, and wiping the mat, and changing pillowcases, most of the time techs are bogged down with timers. So you're gonna come across his body and stabilize the pelvis on the right side. On the left side. So come across and stabilize with your right hand. Come across and stabilize with your right hand, like so. Make sure he doesn't go anywhere. Now the only disadvantage with this one is that, well, the advantage with this one is I can impart a distraction with my body weight. I can just lean back. Okay? Now, that's an advantage. Disadvantage, I'm gonna get some distraction. Now, I will get some distraction at the knee joint, and I could get some at the talocrural. It all depends on where my hand placement is. So if I come above the talocrural joint, then I'm gonna likely get some distraction at the knee joint, most definitely, with this technique. So again, I'll compare, and notice me, I'm bringing it to flexion, a little slight abduction, and an external rotation, because what does that do? Yeah, that puts them in a loose pack position. And again, I get the same assessment as I got with the first technique of performing this. Now, my patients, if I get the same assessment, now I haven't asked them, but we get feedback from our patients as well. If I get the same assessment, my patients should get the same way. He should get the same feeling. He should get the same sensation on both sides. So both sides should feel the same to him. Did either one of your sides feel significantly different? So neither side felt significantly different for him. So most of your patients, if they are extremely hypermobile, or if they are hypomobile, they will be able to tell you what they sense. They will be able to tell you if they sense the difference. So don't forget to get feedback from your patients as well when you are assessing accessory motion. What type of accessory motion did we just assess? A joint plate, which is necessary for what? All motion. Good. Now let's go into them and let you practice. We're gonna do 2 techniques in practice. Dr. McClure, you mind sharing the techniques with me? So I do 2 and Dr. McClure do 2 to switch it up. I know y'all get tired of it. All right, come on. Come on, Dr. McClure. Now the lateral stretch. Go ahead, lie down. Now the lateral stretch is fascinating because the lateral stretch is more so of a distraction. Now I can sit down with this one, but I'm gonna also use my belt with. Oh, that's my scooter ruler. Okay. Now, can you bring me a pillow, please? Make sure you record this. I'm kind of switching this up from the video. I got my belt on the figure 8. I'm doing something a little different here. Put your leg up for me. Might be too high. Put a hip in a little flexion, external rotation. So yeah, this is kind of different from the picture. I'm gonna come here. So I'm not stabilizing at all in the picture, but I'm about to stabilize here. So now, I'm gonna get as close to the hip joint as I can. All right. And so, working through the skin, and now I'm providing a lateral distraction of the femoral head. So does my patient feel that? Okay. Now, I'm gonna ease up off of this. So, does everybody see that? So you can see the amount of stretch that I got. And so now this feels good to me because I'm not, when I do it with my arms, I'm using a lot of arm strength when I do it with my arm. But now I'm using my body. I'm just pushing. My line of force is lateral. Just going straight this way. This is my line of force. Straight back. Okay, now I got another way I could do this, right? So I wish I had a high chair, but I don't have a high chair. So now I need to scoot a ruler. So now I'm gonna lower her, and I'm gonna sit down in my scooter ruler. But guess what? I'm gonna keep my belt on to assist me. Woo. Coming up. So I'm gonna put it around my back now. There we go. So now I'm gonna use my hand, come up underneath. All right, relax for me. So now I have my hand underneath. All right, so you see my hand? I'm still gonna stabilize. It's not showing me stabilizing in the picture, but I'm still gonna stabilize the opposite pelvis. And so now I'm using my hand, and I also can use my scooter ruler to push back to help with creating that lateral distraction. I still want to keep her in external rotation, so I'm gonna drop her off right here so that she doesn't go into too much internal rotation. Okay, and so now I'm working through the towel, I'm working through soft tissue, and once I work through that, I'm able to apply the lateral stretch. And this lateral stretch is more so a distraction than the long axis distraction. The long axis distraction is really more so of a traction technique. This is more so of a distraction technique because now we're distracting the femoral head from the acetabular. All right. Let me see how the other side feels. Any pain or discomfort with that? Okay. Now, I didn't feel any restrictions, but I really don't know until I compare to see. So I can make this a little bit longer. Did y'all see what I did with my belt? I made it into a figure 8 instead of looping it around her. I came through like this, like so. Put that right there. Now this could be uncomfortable, so I'm gonna make it to where this belt port is not against her skin. Okay. So now I got me a figure 8. Now I'm gonna take this, move this over here, kind of bias her into some hip flexion, external rotation. I actually like doing it standing better with the belt. I like this version better than the version that I have on the picture. This one's easier. Stabilize. I'm gonna come right here. And my force is going straight back. So I got the belt as close as I can have it to the joint line without invading my patient's privacy. And then I back up off of it. And as I back up off of it, I'm getting a sense of how much distraction I was able to achieve as well. Does that make sense? Because I'm gonna see it and feel the difference. So I start out working through the towel and I start out working through soft tissue. Once I do that, now I know I can impart the stretch. Now, I need somebody who, Dr. McClure and I are probably gonna come across somebody. Eventually, we're gonna come across somebody who may be abnormal or hyper or hypo on one side than the other. Now, what did you feel with that one?
It was tight.
You felt tightness? So my patient reported feeling tightness, but I didn't feel any difference. So I got her report, but I also had what I felt. So I didn't feel any significant difference from one side to the other with this technique. So if I'm using the standard Paris scale for accessory motion, I would still grade her 3 normal, simply because I didn't notice any difference from side to side. Now in her case, she could be tight and feel tight. So that tightness could be her normal, and we still need to work on that, you see? So she could have adapted to being tight, and that could be her normal, being tight. So we have to look at that. And then again, I'm not gonna sit down this time, but I'm just still gonna use my hand. I'm gonna come around, get right here, and come work through the towel and soft tissue and provide my distraction. So my distraction force is towards me. It's some work. That's the distraction and the lateral stretch, which are both joint plate techniques. The other question was, how do you record if the person is starting in a hyperextended position? So according to Norton and White, so I'm coming back to make sure I teach y'all this, so this won't be an issue in the future when you all go into the courses and document it. So always show your professors the book. You can't go wrong with the book. And the book that they use for National Physical Therapy exams is what I told. And I'm very animated when I talk and speak because I want the person to remember. And this is exactly how I was telling Dr. Benefield. Go to the book, get the students reference the book. And I told her, even when in the practical, what do we have you all to do? I said, if it's in 2 different places, what do I tell y'all to do? Just reference which one. I told her the same thing. It's not rocket science. I said, it's not rocket science. Just get the book and reference the book. So with Norton and White, right? How does Norton and White document hyperextension? So I'm using the knee as an example. So we're assessing knee flexion, active range of motion, right? And this person starts in a hyperextended position. So say the person starts in 5 degrees of knee hyperextension. According to Norton and White, you would document the hyperextension first. That would be your 5 degrees. Then you would put 0 in the middle. So 5 to 0. And if they go to 90 degrees of flexion, that would be the end of position, 90 degrees of flexion. But this is in Norton and White. Dr. McClure found it in Norton and White, okay? So it is in there, all right? And so that's if it starts with hyperextension. So if the person has what they call an extension lag, meaning they're lagging 10 degrees of extension, but really what's happening is they are started in 10 degrees of flexion. So their knee is already flexed in 10 degrees. So you just put 10 to 90 degrees. The starting position is 10 degrees of flexion. The end position is 90 degrees of flexion. So that's how you record it if they're already in a flex position. Does that make sense? All right. So this is just for documentation purposes for board exam. And then in the clinic, what you may see in the clinic, like I use Web PT in the clinic. So when you all go to the clinic, what you may see is the negative number put in parentheses. So for knee flexion, active range of motion, if the person is starting at 5 degrees of hyperextension, you will put 5 degrees in parentheses in your clinical documentation and to 90 degrees of flexion if they get to 90 degrees of flexion. But that's how it would look on the clinic side when you see it. But as far as National Physical Therapy exam, you want it documented according to Norton and White. Okay? Because this is what you may see on the National Physical Therapy exam. Okay? All right, moving on. Right here, I'm gonna bias her to a little flexion and external rotation. And now I'm using my palm of my hand to impart that lateral force. But I am using a lot of my arms with doing the lateral stretch the way I'm doing in the second picture. Then again, I can raise the plate even more. I can do this standing or sitting. So on your practical exam, you all know y'all crunch for time, right? So do what's more time efficient. As long as you're doing it correctly, that's no problem. So if I'm crunch for time, this is gonna be my go-to. I'm gonna come here, go under, make sure I got her in some slight flexion, external rotation. Of course, I may put my pillow under here to make sure she's flexed at the hip, but I'm gonna lift her and bring her to some hip flexion with my arm, work through the soft tissues. Now I'm on an osseous structure. Now I can provide my lateral stretch. Do you feel that? Now, notice I'm stabilizing the pelvis when I'm doing it without the belt on the same side, because I want the pelvis to stay stable. I don't want it to move on the same side. Now notice when I did it with the belt, I came across and stabilized across. That was just a clinical judgment type thing. That was a Dr. Carver's bias. I did that because I didn't want to pull the patient and have the patient come like this right here. So I stabilized on this side because with the belt, I got so much leverage with the belt that if I just go with the belt and not stabilize over here, I can actually create that movement. You see, that's a clinical judgment type decision that I made to do it that way, all right? But if I'm going for timing, I'm going with the hand. I'm not worried about fouling with that belt. I can do it also with the person. I'm gonna go do this one. I was gonna since this is the technique I got, I was gonna let Dr. McClure do this one, but I'll go ahead and knock this one out. So this is one again. Now, I like this one because the hip is flexed. Now with this one, remember with the one where the person, your patient was lying supine, the thing I like about this one is you can drape with the towel and you can get closer to the joint line. It's easier to get to the joint line with the hip flexed than with the hip extended. So now I can get closer to the joint line with my belt. And with this one as well, guess what I don't have to worry about making? Figure 8. So if you did use the belt, this may be your one you want to go with. Because now I don't got to worry about that crazy figure 8, right? So now, make sure this belt is on my buttock. Come right here. And now I'm going to stabilize the opposite side of the pelvis with this one. So look at it in the picture. I'm stabilizing the opposite pelvis. And now with this one, my patient is most likely going to feel a greater stretch. See, this right here is the more effective. Out of all of them, I think this one is the most effective. What do you think, patient?
That's great.
So Dominique said feels great. So now, my patient has hip problems. She already told me. So since I know my patient has hip problems, what am I gonna do? Assess both sides. Kentori got it down now. Just let me know Kentori been getting the reps. She's been listening. Did you know active listening? You get reps with active listening? Nobody knew that, right? Yeah, you get reps with active listening. I felt a pop, see? I'm just feeling and sensing. My patient said, she said a pop, I felt it. But now, see, that may have corrected a positional fault, because now I don't feel it. Good. So, this one is a quick go-to with the belt that I would do in the practice if I had. You know, if I thought I could finesse it quickly, that's a good one. All right, and so y'all can practice that one later.
Glide of the femoral head. So is this a joint play or is it punch motion? What emotion? What is it necessary for? Flexion. Very good. Okay. So for this technique, we are going to do this with we're going to bend the knee for this. Okay. So I can still bend her knee and I can get her up into a bit of a loose back position. She may be in a little bit more flexion. So this is, but she's still going to be in flexion, a little bit abducted, externally rotated. Okay. I'm still going to get the towel. I'm going to get her into full knee flexion. So what motion or what muscle is that going to slacken? Hamstrings, right? So I'm going to put some slack in the hamstrings, and I can come in here like so. I'm going to get this towel as close to her joint line as I can, and I will have to get in here. My arms aren't very wide for me to come in here like so. So a lot of times I get in here and I will, with my shoulder, I will. And in fact, would you mind to throw me a pillow? A lot of times.
And that's why I switch it up with Dr. McClure so that y'all can see, because my arms alone, I got a different somatotype. So for some of you all, you may have to do it like Dr. McClure is doing it.
So I'll get in here nice and snug, and I can use a pillow barrier so I can get my chest and shoulder in here, so I can get against her and I can really get in here and snug it in, okay? Now, if I can get here standing on a staggered stance, I can have her actually scoot toward this side of the table just a little bit more, and that'll allow me to do it standing, okay? So I'm gonna come in here like so. I've got her in as loose packed as I can, but I realize that it's in a little bit more hip flexion than maybe loose pack position. I'm gonna take my hands like this, and I'm gonna come down as close to her joint line as I can, and I'm gonna sink through the towel, through the soft tissue until I get to the firmness of the bone, and then I'm gonna apply inferior glide. Okay? Okay. Alright, I'm gonna prepare, so I'm gonna have you scoot to the other side of the table for me. Alright, so I'm gonna get her up into full knee flexion. Same thing here. Get my barrier for me. I'm gonna get the towel as close to the joint line as I can. Tell you what, no, we're good. Okay. Make sure I'm not pushing velvet too. Sink through the towel, the soft tissue, and I'm gonna rock back and create an inferior glide. Okay? You feel any different side to side? Feel fairly symmetrical to me as well. Okay? So grade 3 normal, firm infield. We talked about this before. This is what Dr. Carter talked about before. As far as part of the capsule, that would be restricted motion. All right, so that's the inferior glide. Any questions about that? Okay. All right. I think or any other comments about that, Dr. Carter?
No, notice in the picture, I don't have a barrier. I didn't use a pillowcase. notice Dr. McClure used the pillowcase. Can you tell them why, Dr. McClure?
Well, because otherwise I'm gonna have my chest right all in her business, okay? So, for me and for my patient's comfort, it may not bother me. I'm a clinician, I know what I'm doing, I know exactly what I'm doing, right? I'm not feeling like I'm inappropriate, but somebody else may perceive that as inappropriate. So, just to make sure we're all clear about things, that's how I do it. This is also, and I was talking to somebody about this the other day, I don't think it was in this class, but this is also, sometimes when I get here and I'm working on techniques in this area, this is when I start having conversations and I'll start talking to them about my husband and my kids and asking them about their, spouse or whatever. So everybody's on the same page. This is professional, like Dr. Carter said, we can educate them why we do it, we can show them the technique in the book, we can show them on the skeleton, but it's just one more thing to just make sure we're all on the same page.
So as men, we have breasts, but we don't have breasts. Typically, men don't have to, worry about some of the things that female therapists may have to be cautious of.
The point is that can be angled a little bit differently as well. You can, if I want to go, so that was a pure inferior glide. What is the next one inferior?
So this one inferior glide as well.
Okay, so you can see that different, if you wanna see that different position, right? I can do the same thing, getting her here like so. Now I may not need the pillow. I may just be able to get here with, I may use my shoulder to kind of keep her resting so she's not falling out to the side. But now I can also come up here like so, get my forearm in line with the position, sink through the towel, the soft tissue, and I can also apply an inferior glide like that. Now, Victoria, what, as far as this glide compared to the other, does one feel better or stronger? Yeah, I feel like I get a stronger. I feel like I can push better than I can pull. So, that is how that technique works. Let me show you on the other side. Scoot this way for me again, please. Side of the table. So I can put her up in flexion, okay? I can get in here again with the towel, close to the joint line as I can. Get my forearm in line. I can kind of get my shoulder in here just to keep her from falling out. Sink through the towel, soft tissue, and apply an inferior glide. So am I unweighting? Not in the sense like we think about with the other ones, because that is what I'm doing. Now, subconsciously, I didn't say that I do this, but when I come in here like this, I'm taking my hand and I'm kind of bunching skin down. It's not as much of a skin stretch as it is with some of the other techniques that we do, but it's just a habit for me, right? That muscle memory, repetitions, right? So I come here like this, I kind of come down with the skin, and then I sink in and create it. But because I don't have one hand up here, you're gonna get a little bit of an unweighting just by the nature of the technique. But it's not maybe in the same sense as when we're doing a posterior glide of the, the MCP. Okay. Does that make sense or help? Okay. So that's the inferior glide. Now, we can also do an inferior lateral stretch. So this is component motion necessary for hip flexion and hip adduction, abduction. Okay, so, and maybe just well, let me just check this, right? So the technique we just did, sometimes you will see people do it like this. And they'll have the patient come up here like this. Have you ever seen this in the clinic? And then get down here and do it that way, okay? So that I can do the technique I just did like that. Again, I have a bony shoulder. This isn't as much of a barrier as it is the fact that I know that my collarbone is really bony, and it may not be very comfortable in her gastroc. So I'm gonna put a pillow here to cushion. I'm still gonna use my towel here. So I could do a pure inferior glide technique, more pure inferior glide technique like I just did, okay? Or I can now adjust the position of her leg, and I can rock her out, get her into flexion, a little bit of adduction, and now I can adjust my force to where I'm pulling more inferior and lateral, okay? So, I can get here, again, make sure patients, okay, with my hands being right here, okay? Sink through position, sink through the towel, soft tissue, okay? Like that. Now, if I can get standing in their position and still keep her here, which I feel like I can, Some patients I can, some patients I can't. I can also stand here more of a diagonal, sink through, and apply the inferior lateral stretch. Okay, you scoot your knees to the table for me, please. So again, she's flexed, she's adducted a bit. I'm gonna adjust the position of my hand, so instead of being a more sagittal plane, that I'm coming toward the inside of the joint a little bit more, so that I can apply inferior and lateral stretch. It's not significantly different, but I feel like with this and the last one, I felt like this is slightly more restricted on the other side. Okay, so I would probably call her a slight hypomovable joint, so grade 2. Okay, for the inferior lateral stretch. Any questions about that? Okay.
All right. Are you gonna do it with the belt?
Well, I should say, and you can also do the same technique. It looks just like the other one, except you're adjusting your pull. Okay? And more lateral than just you're pulling inferior and lateral together instead of straight lateral, like we did on the other two.
So it can be done with the belt as well. Component motion necessary for hip flexion and hip abduction. And so I'm only gonna do one technique because this technique you can see the best. So the technique on the first picture, that's the one that I'm gonna do, and I'm gonna keep it moving because that's the one that can be seen the best, and I think that's the one that can be achieved the best, and that's the most effective with the inferior medial stretch. So go ahead and turn on your side, put you on either side, it doesn't matter, because we're gonna assess both sides. So now, so I'm gonna get his hip like so. So I'm gonna get him to some abduction. There you go. And now I'm gonna take my hand and place it just below. So I'm just below his greater trochanter. Okay. So on the proximal shaft of the femur. And now my force. Do you see my forearm? My forearm sets up my line of force. So my line of force is going to be inferior, like so, inferior and medial. So you feel that, Pujan? So I'm not banging against the acetabulum because my force is inferior and medial. And I'm judging this as I assess this motion. Okay? So this is about as much as I can get. And the inferior medial joint capsule is tightening in this case, preventing me from going into more glide. So I'm gonna assess the other side and compare. All right, go ahead and turn over. So remember, with a lot of our techniques, with many of our techniques, our forearm creates our line of force for us, as shown in the picture. And I'm keeping the plinth low. Although I may have to bend just a little, I'm gonna keep the plinth low so that I can get a good force. Go ahead, roll to your side. There we go. Now, I'm gonna assess the other side one more time. How am I doing this?
Make you feel so.
Okay, now let's go back to the other side. So, I'm having to work hard on this side. That's why I want to go back and sense it. So I know that I'm having to work harder on this side, which I'm feeling greater resistance as I move him into that, right? So now there could be more tension on this side with his inferior medial joint capsule, now allowing me to go in more of an inferior medial glide. So on this side, I would grade him a grade 2, slightly hypomobile in comparison to, say this is non-involved extremity. So this is non-involved extremity, this is an involved extremity. So the involved extremity, grade 2, slightly hypomobile with the inferior medial stretch compared to this side. I had to go back and sense it, so I didn't want to jump the gun. So I wanted to make sure I was feeling what I actually felt, okay? This requires practice, all right? It requires reps, quality reps, all right? Just like with anything else. So that's the inferior medial stretch. Component motion necessary for hip flexion and hip abduction, all right? Very important, all right? So, but everything else I just went through, well, so make sure you practice accordingly. So I'm not even gonna go through the other one because the other one's gonna confuse you. There's a lot of fiddle faddle. Just that first technique, that's what you want to perform for the inferior medial stretch or inferior medial glide. So I gave you, according to Dutton, so we read this today, when assessing joint integrity, we read that we want to verbalize whether it's hypomobile, hypermobile, or normal with the comparison. And I verbalize my infield for joint integrity, assessing joint accessory motion. And you want to verbalize your infield as well, okay? Now, according to Dutton, what does it say about if you're mobilizing convex on concave? What does that clinical pearl say? There you go. Good. Yes. So most likely that's the part that's gonna tension first. That's the part that's gonna contribute to, if it's a normal firm infield, it's most likely gonna contribute to a normal firm infield. And if it's a restricting component, it's gonna be an abnormal firm infield. So on this case, in comparison to this leg, so I'm going back again, so go back and watch my GAs post these videos. So in comparison to this side would be an abnormal firm infield because it prevented me from going into the range of the glide as this one allowed me to go, okay? So I'm gonna consider this one abnormal firm infield. Does that make sense? Now, when you go through your practical, don't fiddle faddle with Dr. McClure and me. Give us exactly what you feel. Tell us what you feel. We wanna know, okay? We wanna know what you feel in comparison. If it's truly normal, symmetrical, state that. But if it's not, let us know. And so on some of you all, we may already know, like Pujan. If somebody gets for Pujan, I'm gonna already know if he hasn't done anything to change it from now and then. All right, but that's your inferior medial stretch. So now I know, what am I gonna do with this information, Dr. Carter? So he comes in complaining about hip pain. He doesn't know the source of the hip pain. I've just assessed accessory motion, right? With this particular accessory motion, it was an abnormal firm infield. So what I'm gonna do, I'm gonna put that as a problem. I'm gonna put an asterisk by that. I'm gonna notate that in Web PT, and I'm gonna put an asterisk by that. And what do you think I'm gonna do with that? I'm gonna put this in my treatment plan. So now performing this as a treatment is not gonna be in my treatment plan, okay? And what I'm gonna do, I'm gonna engage the barrier of restriction, all right? So that may consist of doing a grade 3 and grade 4 joint mobilization techniques, all right? But we'll get to that part in clinical orthopedics. But I'm gonna engage that barrier and I'm gonna try to get to his plastic range. You You all read the chapters on that, right? Stretch strain curve, trying to get into the plastic range. Yeah, y'all read that. That's the beginning of it. Yeah, a solid reading assignment. All posterior glide of the femoral head. Now this is a component motion that serves also for hip flexion and also hip internal rotation. Okay, so let's see. I'm gonna go same side first. All right. So I'm gonna get his hip into flexion. All right. I gotta have him low enough where I can impart my force. I'm gonna bias him just a little bit. I'm gonna bias him just a little bit in hip adduction because I want my line of force to go posterior and somewhat lateral. Okay. Now I got it right here, and I got my forearm in line with that. I'm gonna take my left hand and just come up under the joint line. Up under the joint blade. I should feel his femoral head as I do this. Kind of move our greater trochanter, superior aspect, kind of move into my hand. So I'm using a good amount of arm strength to generate that force. So more so like a posterior lateral force going in this direction. All right. I'm gonna come assess the other side.
It's very similar to like the cephalic movement for the forearm that we were doing. Why is that considered cephalic when this is posterior?
Okay. So if we look at the anatomical position, based on the anatomical position, when we're lying supine and the orientation and the anatomy of the elbow joint complex, when it is called cephalic because with actually an orientation to the humerus and radius and ulna, the radial head or even the ulna is moving towards the head based on the anatomical position. So I'm like this, so anatomically, if I'm doing a cephalic movement through these bones of the forearm, I'm moving those towards my head.
Is that not the same for that, when that's leg posterior? That's what like if you were to straighten his leg out into neutral, but then still apply the same force, that would be moving up towards his head, not posterior.
Not exactly so. Because if I strain his leg, right, and I apply a posterior force, I'm in an anatomical position. If I apply a posterior force, it's going this way. So I'm in an anatomical position right now. I'm standing. A posterior force is going that way, backwards, not towards the head. You see? So the orientation of the hip complex and the orientation of the elbow joint complex, they're gonna be different in regards to that. Now, if I did a cephalic movement of the femoral head, I'm actually doing something like this. You see, I'm moving through his tibia and femur, and I'm pushing upward. And now this is a cephalic glide.
I understand the direction of the force. I just thought with it being in a different position that it would change the name, but that was all I was saying.
Mm-hmm. So now, but good question though, good observation. That's a good eye. So if I come right here, right? Come right here, and you're talking about like so, right? Like so, I'm gonna come right here, and if I do this right here, this is gonna be more so moving in a sense. The only difference is I have his elbow flexed. And the reason why I have his elbow flexed is because what's gonna happen is if you look at the elbow and you look at the fossa of the concave aspect of the ulnar, right? If I come here and do that, then if I do it like this, it's gonna bump into the olecranon process. So I gotta put them into some flexion to bias that and then do the cephalic glide.
Compression is perpendicular to the joint surface versus the hip too, is you're gonna get up here and it's gonna be more parallel to the concave surface, right? Whereas that one, you're going more perpendicular.
Yeah.
Compression kind of thing, in a cephalic direction. And this is more of a parallel to the concave surface and parallel to the concave surface. So I think that's part of it too.
Yep. So if I take this right here, right? If I take it and I do a cephalic glide, I want you to understand this. And my GA, look at this. What's happening? What's happening if I do a cephalic glide of either the radius or the ulnar? What's happening with the arm fully extended? It's compressing. Nothing's happening. Compression forces. The joints are becoming more congruent. So I do gotta bias it in some flexion to do my cephalic glide. And then now, once I bias it some flexion, then I get some cephalic glide and also cephalic movement to occur. So that's the difference between the hip joint. All right. So good. And remember, when y'all can play around with Charlie. Charlie's broken apart now, but hey, you can still play around with Charlie. What's that I heard right there?
Every time.
It pops every time. Back. I've done so much talking in between, I forgot my sensation on my other side. Okay, so now I gotta come back. Fascinating thing about PT, if you like talking to your patients, I end up talking to my patient the whole session. The sessions go by so quick, because we talk about some of everything. What did you say you felt?
More laxity on the left side.
More laxity? Okay, I match up with that. So, cause I thought you were gonna say you felt more restriction on this side, but I felt more mobility on this side. So this side would be slightly hypomobile with the posterior glide in comparison to this side. So I would give you a grade 2 of slightly hypomobile on this side. And therefore, if he's slightly hypomobile, then I'm gonna give him an abnormal firm infield. So typically, posterior capsular tightness. Okay. So that's that. Now that's the posterior stretch. What else? Let's see. I did the inferior. Posterior can be done another way. Go ahead, lie back down. So I can come right here, put the leg right here, cross it like so. And with this one, I am on the opposite side. Opposite side, again, bring them into some hip abduction, come across, place my hand, like so. So working through the opposite side. Doing the same thing, again, assessing both sides. Practice how you play. Get the reps. Get the reps. So, practice how you play. So, another technique. Now, I like this one too. This one is easy. Posterior glide. It could be, it can be done this way. But this way, don't get confused with an inferior glide because my force is going posterior. So I am doing a posterior force with this one, okay? But that one can be confusing, but I'm gonna show that one on this side. It is a posterior force, y'all. Yeah, still felt the same with switching up the technique. But I went through that one quickly. If I had to say which one this one, or working from the opposite side. So probably the first one of each of those previous slides. But you can feel which one works best for you. All right. So practice those, then we'll come to the anterior stretch. All right. So this one is the anterior stretch or anterior glide on the femoral head on the acetabulum. Hey, don't forget you all to verbalize what you're moving on where. So Dr. McClure and I remind you all of that during the clavicle. So it is big, it's major to be able to discuss what you're moving on where. So right now I'm moving the femoral head on the acetabulum. So that lets me know I'm moving convex on concave. So that also orients you to let you know what rule is being applied. Get them like so. Come right here. My hand is just below the gluteal fold. All right, just below the gluteal fold. And I'm gonna impart, and I'm just gonna lean into this. All right, I'm using my body weight to help with this. So I'm not using my arms with his inferior glide. So I'm gonna back up off of that. So you may not feel much with this, and I'm working through the soft tissue, so I'm working through his hamstrings, and then I'll part that accessory motion, that glide. Okay. I didn't feel much on that side, so I'm gonna see what I feel on this side. This technique, you may not feel much anyways. What? So his muscles are contracting. There's some spasm going on. What's that?
I could tell on the left leg that it's doing that, but not on the right.
Yeah, on the left leg. I didn't notice any significant difference between each one of those. Did you notice anything
Yes, sir.
different? Okay, so that's his normal, so he'll be graded a 3 or normal, with a normal, firm, capsular and or ligamentous infield. And the anterior aspect would be the portion of the joint capsule that is restricting him from going into further glide. All right, let's go to supine. So I'm gonna take my wedge, I'm gonna angle it this way, right? I'm gonna place some towels on my wedge. Go ahead, lift up. I'm gonna place this wedge right under his proximal thigh. So now, guess what? Now, this wedge is gonna stabilize his proximal femur. And what I'm gonna do, I'm gonna create an anterior glide by mobilizing the acetabulum on the femur. So now I'm gonna be moving the acetabulum through the pelvis, moving it posteriorly. Relative to the posterior movement of the acetabulum in the pelvis, which direction is the femoral head gonna glide in? Anteriorly. So I come here like so, and just lean into this. And now the femoral head is gliding anteriorly, but I'm producing this anterior glide of the femoral head through the pelvis, moving the acetabulum on the femoral head. You feel that? Mm-hmm. So come over here and do the same thing. Yes, sir. Posteriorly. So I'm moving the pelvis posteriorly. Okay? And thus, the acetabulum is moving posteriorly on the femoral head.
So this is still an anterior stretch?
This is still an anterior stretch. I leaned in like this the first time, right? Now I can switch this up. I could come here like so, and now apply my posterior force like so. See? But his femur is actually not allowed to move posteriorly because of this wedge. So it has no choice but to go anterior relative to the pelvis, the acetabulum. So now, when would I use this one? When I have a patient that I've done the inferior glide on, I've done a posterior glide, all in this position, and I don't wanna change their position, I'm gonna keep them like this to do the anterior glide. So if I wanna do all of them, if I wanna do inferior glide, if I wanna do the posterior glide, and I wanna do the anterior glide, but I don't wanna change the patient's position, I can leave that patient in his position. And then especially if I'm gonna come back and do a lot of work with them in a supine or hook line position, so if I'm gonna come back and maybe have them do some bridging, straight leg raises, clam shells, whatever the case may be, I'm talking about supine clam shells, so not on that side. So whatever the case may be, if I'm gonna have them do some hook line side supine work, I'm just gonna leave them in that position and then follow my supporting interventions with them in that position before I get them to move. So everything I can think of possibly in this position, I would do it and do my supporting interventions that I would have them to do in this position before changing their position.